Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and we are in the middle of our Q&A series answering your fertility questions. These are all voicemails that you have called and left asking some really fabulous questions. Today, we are breaking it down and talking all about male fertility, sperm, and treatments that relate to male fertility in the questions that you're asking. Because I think so often we talk about a lot of the female factors, but half the time there is some male factor present. And a third of the time, infertility is completely due to male factor. So this doesn't need to be just an offside conversation, but certainly a really big important piece of a fertility evaluation and talking about fertility treatment. If you have your own fertility questions, feel free to call the As a Woman voicemail and leave your own question there. That number is 657-229-3672. Again, that is 657-229-3672. Another good place to ask questions will be on Instagram every Monday at nataliecrawfordmd. Some of the questions will be answered there on Instagram and some will be answered in the weekly newsletter. You can get access to the newsletter at nataliecrawfordmd.com/newsletter, and it includes some of my favorite products, books, recipes. It'll include updates, discount codes if I have them, and every week answering some fertility questions so that it's not spammy and some little piece of knowledge you can take away every single week. So don't forget to go sign up for the newsletter, nataliecrawfordmd.com/newsletter. All right, friends, well, we are going to dive in talking about sperm and male fertility, and hope you enjoy the learning.
Hi, I was calling. I've been trying to get pregnant for 18 months now. Did have one miscarriage back in October. We're seeing a fertility specialist now. We've done 3 medicated rounds with timed intercourse. The first 2 were with Clomid, Gonal F, and Overdil, however you say that. And then the most recent one was just with letrozole because with the Clomid, my lining was too thin, they said. And then I got cysts on my ovaries, so they said they didn't want to do the Gonal F. So we did letrozole and then the trigger shot. But recently I found out they had told us my husband's sperm numbers were okay. I just now looked at what those numbers actually were, and his motility was 36% and the morphology was 2%. So I asked them about that because I had seen like the minimum is 4% and 40% or something. And they basically said his numbers are minimally low and that with those numbers, it's still okay to try medicated rounds and IUI. So I wanted to get your feedback on that. For some reason in my gut, I feel like we're just like throwing away our money with his numbers that low, but I really am not sure. So wanted to hear your feedback. I do have a short luteal phase, which is why we started the medicated cycles and timed intercourse. My luteal phase is 9 days. So all of my labs were normal. Every test that I've had done was normal. So not sure why my luteal phase is short, but that's why we started medicated rounds. Now I'm wondering if my husband's sperm count is going to make it impossible for us at this point. And if we should stop trying the medicated rounds until we can work on his numbers and get them up. Thanks for your help. Bye.
This is always a good question. What do you have to do? What do you need to do? And what is going to give you the best odds of success? And honestly, there's not enough information for me to definitively give you an answer. And of course not. I'm not your doctor, but it is important to think big picture. When we start thinking about how old you are, your ovarian reserve, how many kids you want, that does usually play in the discussion for me, because if we are just starting our family journey and we know we want multiple kids, there can be the argument that getting you pregnant with this first one faster is important, and having opportunity to save embryos for the future can also be advantageous. Whenever there is a male factor, IVF is the highest chance of success. That is for sure. So can you just go to IVF? Will that get you pregnant faster? Will that likely lead to a higher odds of holding a baby in your arms? The answer is yes. So you would not be faulted to go there. You should not feel like you have to prove failure at lesser successful treatment before you are offered something that will succeed or has a higher odds of succeeding for your problem. Do you have to do IVF? Well, none of these sperm counts are zero. And even when we start to have lower chance of success, it's often not zero. When I say 1%, that sounds terrible. That sounds like not an effective or efficient way to have a child. And that is so true. It might take years and years and years. But out of 100 people, somebody's going to get pregnant. So it's really important that these numbers, even when we talk about probabilities for a single given person, it's truly works or it doesn't work. So we call it dichotomous outcome and not a continuous line like we act like probabilities are. So when you view it that way, whenever you have low sperm parameters, I don't like timed intercourse. We already are identifying a problem is wrong. So moving on from there should be considered. When we're considering should we do an IUI or not, there is a calculated value called the total motile sperm. And this is taking the sample and looking at the volume, multiplying it by the concentration, and then multiplying that by the motility. And this is trying to tell you how many sperm in the full sample are moving. Regardless if all the other parameters fall normal, this one could be abnormal because you could hit the low end of normal range for everything and have an abnormal total motile sperm count, and not all semen analysis actually calculate this out for you. In order to have the highest chance of getting pregnant with intercourse, the total motile sperm count should be 40 million moving sperm. In order to consider an IUI, we like that on semen analysis to be about 20 million moving sperm, and that is because you lose about half of the sperm in the sperm wash. So the IUI prep, about half the sperm are gone. And I wish it was the bad ones. I wish it was setting them up in two lines. Our abnormal ones got in one line, and the good ones got in another line. There's this misconception that IUI is selecting the better sperm, and that's not true. It is just selecting sperm, and half of them don't make the cut. Because IUI success is best if you have at least 10 million sperm that are moving in the post-wash, meaning 10 million moving sperm are going into the uterus, and you lose half, we're going to want to see about 20 million moving sperm as a low end of quote-unquote acceptable in order to want to proceed with an IUI. And if it's lower than that, could you do an IUI? Do we do them? There's always conversations and every case is unique, but we are decreasing the odds that it will work. So if you're asking, is this going to work? Does this have the highest chance of success? The lower that number is, the total motile sperm, the lower those odds are. Now, this doesn't even talk about the morphology. So morphology is the shape of the sperm. There's different sperm counts, limits. So the most common or the most accurate is called the strict criteria, the Kruger, which wants 4% or normal forms to be present. There's another World Health Organization, a WHO, and they have different limits. So always look at their reference range when it comes to morphology. Isolated morphology alone is different than abnormal morphology in context of other sperm abnormalities too. And I think sometimes people just jump it all together and they act like, oh, morphology doesn't matter. What is called isolated teratospermia and isolated abnormal morphology may have less reproductive implications if all the other counts are perfectly fine. May just be how some men make sperm, and it might not reflect the functionality. However, there's a lot of things that impact both the shape and the motility of the sperm, or the shape and the concentration of the sperm. And so when we have more than one abnormal parameter, I get more worried that it's truly pathologic and impacting function. Just in principle, when you think about a sperm's job to protect the DNA in the head and to swim, attach onto an egg, and fertilize, it really does take normally shaped sperm because if you have two heads or two tails, you're not going to be able to protect the DNA as well or get to your target like you need to. And the analogy I always use for an IUI is imagining a football field. And what we're trying to do is get your players further down the field. So if you're trying to make a goal, it's going to be easier from the 50-yard line than from all the way across the field. However, if all your players have broken legs, broken arms, they're all injured, they're still injured at the 50-yard line. They're not magically better players just because you got them closer to where they need to be. And where an IUI does help, it does get them closer to the goal, and it does get rid of obstacles. One of the Texas football games we went to this year, the crowd got really angry and the students all threw water bottles onto the football field. So you can imagine that debris, that trash is going to make it a lot harder to play football. And IUI is cleaning off the field. So you're definitely getting all the water bottles, all the trash off the field, and you're getting to start closer to your goal. But if the players suck, they still suck. If they're injured, they're still injured. And just because you start at the 50-yard line doesn't mean you make the goal or win the game. So the whole point there is to try to improve the odds. And certainly there's more that plays into if you should do that or not. When there's male factors present, typically that's going to drop your monthly chance of getting pregnant down to about 2 to 3%, depending on the severity. You're not going to get that number higher than about 8 to 10% with an IUI, even when you combine it with ovulation induction. It's important to remember that once you have infertility, your odds of getting pregnant are less than your age-related chance. The longer you've been trying, the lower it is. The longer you've been trying, the greater likelihood you need more aggressive treatment like IVF. None of this means it'll only work like that or that's what you have to do. But as far as that gut feeling of thinking maybe doing IUI cycles isn't going to move the needle much, certainly the most probable outcome is that it won't and you will be doing IVF. So I do think there's a greater discussion about the big picture, your goals, your age, the number of kids you want, if your insurance covers anything, how much everything costs, your odds of success, to help you decide what to do. Lastly, especially if you have two factors impacted like motility and shape, what are their exposures that we can improve upon? Are we using marijuana? Are we drinking a lot of alcohol? Are we smoking? Are we vaping? Are we sitting in hot tubs or saunas? Are we cycling an hour every day? Are we sitting with our laptop in our lap? Are we eating a lot of processed foods or sugar? Are we taking antioxidants? Are we eating fruits and vegetables? Big picture things, sperm, because they only live for a total of 90 days, you can make a change right now and see totally different sperm in 3 months. So that's one nice thing about how sensitive sperm are to their environment, is that you can make a positive change much quicker by changing your environment and your exposure. Okay, we're going to be answering a few more questions. I know that one covered a lot, but you can call and leave your questions on the As a Woman voicemail by calling 657-229-3672. Again, that is 657-229-3672.
Hi, Dr. Crawford. I have a few questions that I would love answered about my husband's fertility and mine. We have two young children, one's 6 and one's 3. We had a miscarriage between those, and then since the 3-year-old, I've had 2 miscarriages. I had a hysteroscopy in December to fix a septum. We just did a sperm test last week, and it came back. His overall amount and count is great, but his morphology is 3%. And I guess my main question is, since we have 2 already healthy children, does it seem more likely that we would be able to get pregnant again even with that low morphology? Is it likely that those miscarriages were caused because of the morphology? There were early miscarriages, like 7, 8 weeks, both of them. I'm curious if that could have anything to do with any of what I've been going through for the last 2 years. So I would love your thoughts on that and just any knowledge you have on that. Thanks so much. Bye.
Okay, my answer here is that 2 things can both be true, and they may be related and they may not be related, because morphology of sperm is the shape of the sperm. That can be due to, 1, the world around you. You can see more abnormal sperm With age, with exposures, with toxic behaviors, with poor dietary habits, with obesity, with illness, with lack of sleep, you can also see that with development of the testes, just how the testes are made. So isolated teratospermia, abnormal sperm shape alone, does that impact your fertility? Does that cause secondary infertility? Stepping back, secondary infertility is when you get pregnant with your first, second child, but you're trying to add to your family and you're having trouble. A lot of this does come from either one, age, two, diseases that happen with age. We have more inflammation in our body, we have worse sperm counts, we have endometriosis or adenomyosis, so chronic inflammatory diseases. Because sperm does change dramatically, it can every few months. Having children before is not protective of normal functioning sperm now. Globally, does it mean you have improved odds of success over somebody who's never had a child? It does, but not from a sperm standpoint, more from a female standpoint that your uterus has implanted an embryo before and you've carried a baby. So sperm is one of the top causes of secondary infertility because it can fluctuate and change dramatically over time. Things that can cause abnormal morphology can certainly contribute to infertility and miscarriage. Let's use marijuana use. Marijuana use was not studied for a long time, illegal drug, hard to study it. As it has become legal, acceptable in some places, we now are having more robust data that is telling us marijuana suppresses the HPO axis, which means the brain's communication to the testes to make both testosterone and sperm. It also causes inflammation, which can lead to insulin resistance, obesity, and further hormonal disruption. Just because it relaxes you potentially doesn't mean it's relaxing your body. It is stressing your body out. Marijuana use has been associated with decreased success with IVF, decreased success trying to get pregnant, meaning longer time to pregnancy, and with a higher rate of miscarriage. So marijuana use has also been associated with having abnormal sperm morphology. So that's an example where the sperm morphology may be off, and the reason why it's off may also be a reason that is causing you to have pregnancy loss or secondary infertility. Globally, as we get older, more of our eggs are genetically abnormal, so that's likely some contributing factor that I don't think can be ignored. But I don't just breeze off abnormal morphology without thinking through the big picture and really diving into all the things that can influence morphology and if there's any room for change or modification in any of those. I think what should be reassuring is a study came out this year looking at fertile men, people who are not having trouble, and showed almost half of them have an abnormal morphology. So having abnormally shaped sperm is quite common currently, and for a large portion of people does not reflect an inability to get pregnant. I liken this to your egg count. You can have a low egg count, and that doesn't mean the functionality of ovulating or your egg quality is also low. So can you still get pregnant if you have low ovarian reserve as long as you're still ovulating? Yes. However, my big disclaimer is always why. If your egg count is low because you have endometriosis, and endometriosis has chronic inflammation, and we know that that has a strong association with infertility, then you're certainly going to have trouble getting pregnant, and it's not due to the low ovarian reserve, but both of those things, the low ovarian reserve and the infertility, are tied back to a common cause. And one criticism I have about medicine in general is that we don't always do our deepest dive for what that causes. And sometimes it's because it's expensive, impossible. It's not going to change the plan. Maybe you're 38 and you want another child, and IVF is the decision because no treatment I can do is going to improve the odds of success over IVF if you're 38 and older. So it makes sense sometimes to say, hey, we found this. This is true. And I'm not going to go on this big search because it's going to take time, money, and I'm not going to do anything about it. But that's a really different conversation than somebody who may be 29 or may have other factors, or maybe there is a modifiable variable and just you haven't even been given the opportunity to explore that or to tell your doctor or to have a discussion. So this is something that I don't think there's one universal answer for. I would say that low morphology itself is not causing miscarriage, but my question is, well, why is the morphology low? And is there something that's connecting everything that possibly is contributing to the position you're in right now? Sending lots of love because I know it's hard.
Hi, Dr. Crawford. Thank you so much for taking my call. I'm a big fan of your podcast. I'm calling because I have a question about just how to go forward with my husband, who has been treated for testicular cancer. So I'm a 34-year-old cis woman, and we conceived our daughter. She was now 2.5 after about 2 cycles of trying, and that was about 1.5 years before he was diagnosed with testicular cancer. And so he was treated with orchiectomy, 4 rounds of chemotherapy, and retroperitoneal lymph node dissection. And as a result of all that, we don't know if he's producing sperm or not, but we're not able to get sperm to egg on our own at this point. So we're looking into trying to conceive our second child, and based on what I've learned from your podcast, I think that our odds of IUI would be pretty good. He was able to sperm bank before getting treatment, and he was able to go in 6 times. I know that. So I think we have a pretty good amount of sperm. And from what I've seen on the semen analysis, his counts were like in the 80 to 90 million range, and motility and all that looks pretty good. So I don't foresee any problem with IUI, but I'm actually kind of wondering if IVF might be smarter because we have the progeny benefit, and so that would cover, we have 3 smart cycles of that. So we could do IVF and test for aneuploidy and all that good stuff and have it covered. And then I was thinking in the event that we want to have any more kids down the line, it might just make things easier if we can maybe get embryos now and save them for later. And then I know, like, since I'll be turning 35 in April, I know that our odds of miscarriage are going to be higher. So I just keep thinking, like, what if we do IUI, it takes 3 tries, and then I end up miscarrying, and then we have to do it over again. And by then, you know, we would have been better off doing IVF. So I'm just kind of wondering what your thoughts are on that. And if you have the time to answer this question, I greatly appreciate it. Thank you.
This is such a well thought out question. And honestly, it's bringing so much joy to my heart. Not that you've gone through so much, oh my goodness, but that you're able to really advocate from a place of education because of some of the information you've learned. So thank you for sharing that. There's no one right answer. And you already hit this nail on the head. Are you a good candidate for IUI? Absolutely sounds like it. So if somebody's not in the exact same position, let's just think it through. You banked sperm and now you no longer have sperm. This could be due to cancer treatment like we see here. I've also seen this done if somebody needs to go on hormone replacement. Some men need to be on testosterone, and that's going to diminish their sperm counts. I've also seen this, for gender transition, if somebody has sperm, but then they are taking, medication that's suppressing their sperm production. And I've also seen it for donor sperm. There are cases where maybe you have a baby from donor sperm, but you only have a limited number. So the big universal arc in all of these cases is that you have a limited resource, and that resource is sperm. And you have some frozen. It's going to be frozen in different vials and different amounts. If the sperm is coming from a sperm bank, and you should check from when your husband banked his sperm, because everybody does it different. Did they just bank it in what we call IUI allotments, these big amounts? Sperm banks often will do small little amounts, IVF allotments as well. You cannot go back and get more sperm. So you need to act as if that is the most precious resource it is, because it probably is in this case for your goals. It is the genetic tie to your future. So in that case, IUI. If you're going to be a good candidate for IUI, what do we want to see? I love to see vials frozen with at least 40 million moving sperm in them, as we talked about earlier, so that we know we're going to have enough. 20 million would be acceptable, but I'd love to have more. I would love to see that you've had a full evaluation, ovarian reserve, that your fallopian tubes are open, the inside of your uterus is normal. This is not at all the case where I would ever roll with somebody who said, we don't need to do all that testing because the problem is you don't have sperm. We just need to put a little sperm inside and you'll be fine. I hope we just put sperm inside and you'll be fine, but the sperm is much too valuable to be rolling those dice. And if you're gonna thaw a vial, you need to have full confidence that you have checked everything you can to have the highest chance of success. And if it's going to be IUI, I would want to make sure you're ovulating, you're using a trigger shot, you're doing ultrasound monitoring. We've done all the pre-testing that we need to. So your tubes are open, your uterus is good. What's your ovarian reserve? all of that aligned, could you do IUI? Absolutely, you could. And big picture, where's my line in the sand? My line in the sand is leaving 2 vials of sperm for IVF, not just one. Do not just leave one. At minimum 2, would really love 3 because I can't go back and get more. So could you do 2 or 3 IUIs and still have multiple vials of sperm for IVF? You absolutely could. Is IVF smarter? Well, in this context, you have so many smart cycles. This is a discussion for another day, but let's imagine it's like a debit card. So you have a debit card, and when you are swiping your debit card, whether it's for IUI or IVF, you are debiting from your money. So we don't know what the future will look like. Sometimes IVF uncovers problems we didn't know existed. So you use that debit card resource more wisely by doing a treatment that we know is going to be, number 1, more successful. Number 2, uses your most precious commodity, which is not your money, but your sperm, in a smarter way. I need less sperm. I can save more vials. I hopefully would make more embryos, decrease the chance of loss by doing genetic testing, maybe save embryos if you want to add another child again in the future. I think that's the next part of this picture. If you 1,000% just want to add one child, you have a little bit more leeway. If you think there's a 0.1% chance you'd want to have 2 more kids, IVF clearly is the answer. IVF is the only thing that exceeds natural conception. It uses your sperm in a much more efficient way. IUI, we wouldn't do except to try to save money, honestly. That's one of the reasons why we do that. So in this case, where it sounds like you have a benefit, you may not have that benefit forever, you have sperm, it sounds like you could take both paths. You could do all your testing, do 2 or 3 IUIs, and if not successful, go on to IVF. But it would be a faster, potentially smarter plan, a better use of your resources for sure. And if there's even a smidge chance of wanting more than one child, going down the IVF road is going to be just a safer bet. And at the end of the day, we don't control the outcome. We control our education and the choices we made along the way. And knowing you're making a choice that's giving you the highest odds of success and using your resources the most wisely is always going to be a smart bet. All right, one last question, but you can call and leave your questions on the voicemail at 657-229-3672.
Hi, Dr. Crawford. So first of all, huge fan of your podcast. I wanted to ask if you could talk a little bit more about sperm morphology. I listened to your male fertility episode where you go into the components of a semen analysis, and that was very helpful, but I'm really getting mixed messages about how much morphology really matters. So my husband had a semen analysis done. Everything looked great besides the morphology. That was only at about 1%. But motility, numbers, everything else looked perfect. He can't really make any other lifestyle changes. He already works out. He doesn't smoke. He eats a plant-based diet. He's been, for the last year, we've been trying to conceive on all of the necessary supplements that you're supposed to take for that. And so his urologist thinks that we have a good chance of conceiving naturally with that 1% morphology. My REI specialist is leaning towards trying IUI first. But then studies online are saying that anything less than 4%, you really should be looking at IVF. So wanted to see if you could dig a little bit deeper into morphology. Does it really matter that much? And, what are your chances of conceiving naturally when a male has morphology of less than 4%? Thank you.
Okay, addressing this one more time because it's such a good and common question. I probably have 5 different voicemails that are all titled sperm morphology. Sperm morphology is detected a lot of different ways. We think this is often computerized. My lab, we do use a computerized system. A computer looks at the sperm, measures everything, and can determine from its photo how many are abnormal. Much more objective, accurate assessment. However, for many, many years, and in most places, do a semen analysis and a morphology by counting sperm on a grid is how they get the count, and then they stain some sperm on a slide, and then they look with their eyeballs to determine this. Highly subjective. So there's a lot of variation person to person. Some of the best studies use a single person to do the entire evaluation or the analysis so they can try to get better data. But I think we have to understand that there's a lot of difference in how places determine morphology that can impact some of the results. What do we know? Morphology, along with any other abnormal value, is more likely to be pathologic and associated with a significantly higher rate of infertility. Morphology alone can be common even in fertile men, but it is not normal. Just because something is common doesn't mean that it's normal. The bigger question is, why is the sperm abnormally shaped? It sounds like you've already done a really good assessment of all the other variables that possibly could contribute, have eliminated what you can. You can't do more than that. Also, I feel like the worse the degree of the abnormality, so the lower the number of sperm that are normally shaped, the bigger the impact that potentially is going to have. Because if you have a very low percentage of normal sperm and it's almost zero, that to me is making me really concerned if the sperm can do its job. I don't like to sit on any normal sperm parameter, largely because the difference in finding out that somebody who has no infertility has abnormally shaped sperm is much less significant than somebody who's been trying, who's having infertility, who's getting older, who wants to have multiple kids. So I agree. Any abnormal sperm parameter, if it meets criteria to consider an IUI, we talk about it. Again, for an IUI, if the players can't play, I'm not helping them play, I'm just putting them further down the field. So there's some contextual, bigger picture goals: age, ovarian reserve, number of kids you want, and how many cycles you're going to do. If you are under age 38, it's not unreasonable to try 3 IUIs and then go to IVF. Isolated teratospermia can fall into the unexplained infertility mild male factor category. However, IVF clearly is going to have higher rate of success, even in this context, especially with ICSI. And IVF is going to have a higher rate of success skipping, bypassing IUI if you are 38 and older. So a bigger picture discussion, but I think to the point of it, it sounds like you've done due diligence of looking at what could cause this and thinking through it all, looking at his general health, and sometimes you just can't change it. It is what it is. Last note, sperm changes every 3 months, so I always consider drawing another semen analysis if it would make a difference. You could have a cold, you could have a flu, you could have gone to a bachelor trip in Vegas. Those things can transiently impact your sperm, and they may be different a few months later. So don't forget that sperm does change, both good and bad, and that it could help to get a second test. That said, there may be variables where you already know what you want to do, and there's no reason to spend more money or go through additional testing if it's only going to delay you getting care. Okay, guys, excellent questions about male fertility. I hope some of these helped, and keep your questions coming. We are in the midst of our Q&A series over the holidays. You can call 657-229-3672. Again, that is 657-229-3672. Feel free to follow along on Instagram at nataliecrawfordmd and sign up for the newsletter at nataliecrawfordmd.com/newsletter. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel nataliecrawfordmd. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.